So just to have a brief kind of review, these are terms and concepts that you need to know that are basically graphically or mathematically defined. So here's a plasma concentration over time curve for an orally administered drug, where you see there's a lag time in terms of when the drug was first administered to when you can detect it in the plasma. Okay, this demonstrates liberation, absorption, and distribution. The onset of activity is governed by when there's a noticeable change in physiology. And so for something that controls uh, blood pressure, you would start to see a reduction in blood pressure at this particular time. And at Cmax would be the time to the peak concentration of the drug, when here you'd be looking at the maximal reduction in blood pressure. So here you'd see maybe a reduction in 5 millimeters of mercury, and here you'd see a reduction in maybe 20 or 25 millimeters of mercury in terms of a hypertensive patient. The duration of action is how long the drug persists, and it kind of goes along with how long the activity is going to be demonstrated. So just one simple concept is that there may be drug in the system, but there may not be a physiologic response happening. And so the duration of action really refers to how long the drug is in the system that produces a physiologic response. The length of time this occurs is demonstrated by this line right here. As the drug reaches its maximal plasma concentration and produces its maximal physiologic response, there is a reduction in terms of the amount of drug in the plasma, and this is the elimination phase of this particular drug. And so this elimination is governed by both renal and hepatic elimination, as well as a few other routes, which we'll describe later. This particular ceiling that's not even on this chart is the maximal therapeutic concentration. This is the minimum effective concentration. This is the smallest amount of drug that produces a physiologic change. This is the maximal amount of drug that produces a physiologic change that is not toxic. And the gap between these two markers is the therapeutic range or the therapeutic index. And at this phase, we've got an elimination of the drug governed by, as I said before, both renal and hepatic processes. And as the drug gets eliminated, it gets removed obviously from the plasma and goes to undetected levels. Okay, and so that brings up our next pharmacokinetic parameter, which is called metabolism, often called biotransformation. And here, biotransformation is the process by which a drug is actually chemically converted in the body, mostly by the liver, from one compound to another. More often, it's a nonpolar compound to a polar compound. And the way in which these drugs become converted is really dependent upon a group of enzymes that exist in the liver called cytochrome P450 enzymes. And they metabolize both foreign and domestic compounds and biomolecules, and they convert them into other molecules. And so there's a whole list of compounds that can be biotransformed or metabolized by these. In terms of drugs, we think of these compounds as being responsible for activating them, but also there are some compounds that deactivate them or metabolize them into other versions of the drug that facilitate their removal from the system. Endogenous substances include cholesterol, steroids, prostaglandins, prostacyclins, and thromboxanes. These are also biotransformed by these same enzyme families. And so interactions with these enzymes play major roles in drug-drug interactions, drug-herb interactions, and drug-food interactions. And so when the pharmacy talks about these particular drugs or these particular drugs and herbs have an interaction, this is more often the interaction that they're discussing. Okay, and so the liver is the major site of the expression of these cytochromes, but these cytochromes are also found in the gut, in the skin, certain components of the lung, as well as the kidney as well. All right. Another thing to remember is that these cytochrome enzymes can be induced, and so there are examples where you can increase the synthesis of the enzyme, and so there are different receptors that are responsible for increasing the synthesis, and these have physiologic consequences, and these consequences are listed here. And so if you induce a CYP enzyme, you can either enhance the inactivation of a drug after repeated administrations. You can enhance inactivation of a co-administered drug, and you can enhance the toxification of another drug. And so three different physiologic outcomes that are all caused by CYP enzyme induction. Of course, there are CYP enzyme inhibitions as well. And so here you've got decreased inactivation of a drug, which leads to increased therapy. And really kind of the best way of describing this is looking at something like warfarin or Coumadin. And so too much therapy would induce bleeding. And then this diabetic drug, too much therapy would produce hypoglycemia. Okay, and so then three different physiologic outcomes exist in terms of these enzymes being inhibited. And so in pharmacology, there are ways in which we can induce enzymes to be activated, and we can induce enzymes to become deactivated. And we'll spend lots of time looking at the different interactions of these enzymes with their requisite drugs. The next phase is elimination. And elimination is really just looking at how efficiently a drug is removed from the system. And the main topic here is looking at clearance. And so it's the volume of drug that is completely removed for a unit time. And you can kind of think of it like dialysis, where we're physically taking the blood, we're removing some component of it, the drug, and we're returning the blood back to the patient, and the drug leaves. And so, our kidneys are basically little dialysis machines, and they're responsible for removing a lot of the drugs that are in our bodies. And so this elimination can be mathematically modeled. We can look at it in terms of a dose being eliminated from one body compartment, and we can also look at it as a dose existing in two different compartments, and one of these compartments is responsible for elimination. And so this is what that would look like. Here's the one compartment model. Before administration and after administration, the drug distributes to the entire body. And this would be in contrast to a two compartment model where you have deposition of drug in specific anatomic compartments, followed by at least some distribution equilibrium that exists at some time later. And so this is really kind of the introduction to pharmacokinetics and dynamics. Remember, kinetics is what the body does to the drug, and dynamics is the relationship between the drug concentration and the physical response at the site of the activity. And so often termed as what the drug does to the body. And so this is the end of the introductory pharmacology material, and we'll revisit some of these topics throughout the curriculum. This next slide is, I think, really helpful in terms of how do you study for pharmacology. And really, pharmacology is at the intersection of medicinal chemistry, basic pharmacology, and clinical pharmacology. And so clinical pharmacology is really drug therapeutics, and it's looking at evidence-based medicine of drug X in disease Y, and how do I use this drug? Basic pharmacology is mechanism of action, molecular target, side effects, toxicities. How does the drug work in a specific disease state? And most of our material is going to be at this intersection right here. We're going to rely on some of the medicinal chemistry components, looking at how do we know what a drug is going to do just by looking at its structure. And so its chemical structure is going to tell us that, oh, this drug is going to be a beta blocker. Oh, this drug can cross the blood-brain barrier, and this other drug cannot. And so this is kind of the intersection of this basic science into a clinical science. And so we'll come back to a lot of these concepts throughout the curriculum, and you'll be well versed in all three of these different languages.